Thanks for the introduction, Winetta. Welcome to today's program, Healthcare Reform, Containing Costs, Improving Outcomes. There is no escaping the fact that we all need healthcare, if not today, at some point in our lives. And the cost of healthcare is reflected on our paychecks, in the cost of doing business, and the cost of our government. Healthcare costs have ranked among the top concerns for U.S. voters for well over a decade. It's no wonder that Americans remain anxious about the impact healthcare costs have on our pocketbooks and tax bills. Of equal concern, especially with an aging population, is the availability and quality of healthcare services. There's no question healthcare costs, availability, and quality will be under continuous scrutiny for public policy improvements. Today, we've invited two experts to help us frame the questions. Can healthcare be reformed? Can costs be contained? Can health outcomes be improved? Before I introduce our guests, I want to take a moment to thank Alaska Communications, ConocoPhillips Alaska, Northrim Bank, and the UAA Institute of Social and Economic Research, otherwise known as ICER, for their support and underwriting of Commonwealth North's programs and operations. Your support is vital, and we thank you for your generosity. I particularly want to thank Ralph Townsend, Director of ICER, for bringing this program to Commonwealth North. Ralph, thanks for your engagement on the Board of Directors and the many insights you bring to that role. Now, let me introduce today's panelists. Scott Leitz. Scott Leitz is a senior fellow with the Health Department at the National Opinion Research Center at Chicago University. At NORC, he has been engaged in projects examining Americans' opinions about healthcare, reviewing Medicare and Medicaid reform efforts, and he led a team advising the Healthcare Transformation Project. Scott previously worked in the state of Minnesota, where he served as the CEO of MInsure, the state-based health insurance marketplace. At MInsure, he oversaw the enrollment of more than 500,000 Minnesotans in the program, focusing his efforts on improving the customer experience, enhancing the functionality of the state's website, and expanding marketing strategies used to promote it. Leitz has also worked for the Healthcare Cost Institute and the Minnesota Department of Human Services, where he oversaw the state's $10 billion Medicaid program. Leitz has a master's degree from the Humphrey School of Public Affairs at the University of Minnesota and a bachelor's degree in economics and mathematics from the University of Wisconsin-Eau Claire. Also with us today is Adam Crum. Adam Crum serves as the commissioner for the Alaska Department of Health and Social Services. He was born and raised in Alaska and has more than a decade of experience in the private sector in strategic management, organizational development, executive consulting, and working on multi-billion-dollar projects. Commissioner Crum is active in community service organizations and has served as a board member for groups like the Salvation Army and My House, a group that works specifically with homeless youth. Both groups work with clients dealing with mental health, substance use disorder, transitional housing, and workforce development issues. Prior to being appointed commissioner in December 2018, Adam was executive vice president of his family's company, Northern Industrial Training. He is highly regarded in Alaska's business community for his ability to establish and lead effective teams. Crum earned a master's degree in environmental health sciences at Johns Hopkins University and did his undergraduate work at Northwestern University, where he earned bachelor's degrees in psychology and pre-med. Commissioner, welcome. On behalf of Commonwealth North and our audience today, thank you, and again, welcome to our panelists. Before the panelists begin, I extend my thanks to the Commonwealth North members who are online with us today. We're grateful for your participation in programs and study groups, as well as your commitment to citizen engagement in public policy. For those of you who are not members, we always want to take a moment to thank you and invite you to also join Commonwealth North. We'll provide a link for you in the chat window to learn more about membership options. Now let's hear from our guests. Scott, please unmute your microphone. The floor is yours.
Great, thank you, Scott. And good afternoon, everybody. As Scott said, I'm Scott Leitz. I'm a vice president with NORC at the University of Chicago, and I'm really excited to be able to talk with you today about kind of some trends and what's going on in healthcare these days, in health reform in particular, some directions that we're picking up around kind of where the Biden administration might be headed, as well as where some states are focusing some of their efforts in moving forward on the very important issues of lowering healthcare costs, of improving healthcare quality, of improving the experience of patients, and the ability for healthcare providers to operate. This is a really exciting time, I think, in healthcare generally. the past year plus of COVID-19 really disrupted many facets of the healthcare system and the way that patients accessed care, the expectations that people had around how they could access care, and related issues. So it's a time when states are really thinking differently about how they can deliver care. There's a new administration in Washington that has certainly some directions that it would like to go. And so in my remarks today, what I'd like to be able to do is to highlight some of those areas that we think are likely to be emerging and areas of opportunity. And as you go about your work in Alaska, how you how that frames up relative to where the initiatives are there. I'll mention, I'll talk in a few minutes about this in a moment, but NORC had an opportunity had the pleasure of working in Alaska in 2018, 2019, and working with the Alaska Healthcare Transformation Project. And I, before the cameras came on today, was commenting to several of the folks that we do dearly miss our ability to get up and see you all up there. It was a lot of fun, and we had just such a wonderful time working with various stakeholders in the state. And I'll reflect a little bit on some of the work that we did, although I won't go into a great deal of depth about it, but I do want to sort of tie back what we're hearing nationally around where some of your initiatives are and how they might align and be informed by that work. I want to take a few minutes to talk about I'll take a few minutes and talk about some of the work that we did in Alaska. As I mentioned, I'm not going to go into a great deal of depth, but I do want to make a few observations that I think are relevant. Then I'm going to turn and talk a little bit about some of the healthcare priority areas, where some of the healthcare priority areas are that we're hearing emerging from the Biden administration, what we're hearing when we're talking with states around kind of where their interests lie. I'll do my best to tie that to some of the Alaska context that we learned and understood during our work up there. But I do also sort of want, I know we'll hopefully have a robust time for some questions as well, since that is some of the best way to get information out. Real briefly about NORC, I'll just tell you who we are. I'm with NORC at the University of Chicago. As Scott mentioned in his introduction, I came to NORC after a long career at the state of Minnesota in a variety of different roles on the healthcare policy side. But NORC is a nonprofit, nonpartisan research or social science research organization. We're affiliated with the University of Chicago, but we're a separate organization, a separate entity. We've been around for about 80 years, and we have offices in Chicago, Bethesda, Boston, Atlanta, and San Francisco. And slides are popping up. And I'm part of a broad group of folks who work in our health group within NORC. We have experts who work on the public health side, in the health sciences, in healthcare evaluation, and in the area that I help to oversee, which is our healthcare programs research area. And you can go to the next slide, or am I able to advance? Okay, thank you. I wanted to reference, I've made reference to this earlier in my remarks, but I just want to sort of mention it again. In 2018 and 2019, NORC contracted with the Alaska Healthcare Transformation Project. And I want to pause to just acknowledge the generous funding and work that came from Sandra Heffern and the project management committee and the convening group that helped us kind of do all the work on this project. But we produced a series of reports that one was a historic project scan of looking at things that had been done in Alaska over the course of the last 10 to 20 years. A meta-analysis of past studies. Y'all definitely have studied healthcare quite a bit in Alaska over the course of the past 10 to 15 years. There were a number of studies that we drew upon to try to tease out some overall lessons about what those studies had found in a broad way. We brought back some promising health reform initiatives that were going on in other states that might be applicable to the environment that was operating in Alaska. We looked at Arkansas and Maryland, New Mexico, North Carolina, Oregon and Washington State. And then out of that, overall produced a roadmap to reform that had hosted a series of recommendations around next steps for Alaska's healthcare system. You can find the information. Just provided the link to the Healthcare Transformation Project website there if you're interested in seeing those reports. But let me just briefly say a couple of things about that work, and then I'll pivot to more of our national work. One was that one of our key findings around that work was the need for better data and information. As we were digging in one of the sort of key areas that we were asked to look at is what was driving healthcare costs within the state. And we were able to do that from some secondary and outside data sources, but one of the things that seemed to be, at its core lacking was real current and detailed information about where some of the healthcare costs were being driven from. And I know there's so we made a specific recommendation area, and I know there's been robust discussion over the course of the last year or two in the state around what some of those initiatives might look like, but I wanted to reference that since that was one of our sort of key findings. The second thing I'd like to say is that we work at NORC across a range of different states, and I knew this from being a former state official as well, is that every state is unique, and they all have their own histories, they have their own unique geographic, political, care delivery, different environments that cut across. Alaska's no different, although I think I could even say that you're more unique than most in the sense of being very large, very, very large, and in frontier areas that other states simply don't have. But a lot of the struggles that the healthcare system has in your state as well as other states related to costs that are too high, that incentives that aren't aligned, and quality below levels where it could be, are shared across states. So while those every state differs, every state does share sort of that common challenge. So I wanted to sort of note that one of the things that I think as I go through what we're hearing around where some of the priorities are with the Biden administration, what you'll hear is some of the themes that I think came out in the work that we did with the Alaska Healthcare Transformation Project, largely because a lot of those issues are shared, they're common, and they're ones that while making progress, that progress has been slow on those things. And so some of those same initiatives and interests, I think, will be echoed as you go through that. And then the final thing I'll say before moving into talking about that is noting up front that, changing a health system and reforming it to control costs is a really complex undertaking. And I've often said that in some ways expanding coverage is the easy part, because you just give people insurance coverage and you pay for it, and that I'm simplifying it, but in some ways that is an easier aspect because you have a transfer risk that occurs, and that can be accomplished fairly more readily than, for example, transforming a whole system to really operate in a more aligned way, given the histories and otherwise that have occurred over time. And so at its core, it's incremental and it's doable, but I think that we all have to recognize that sometimes these changes do occur over a period of years, and those increments can build up over time. All right, can we go to the next slide, please? So that I'd like to talk for the next little bit of time about some of the things that are sort of impacting on how thinking is occurring both at the federal and state level around health reform and about health policy and public health writ large. So I'll talk initially. So on the next slide, I'll just state the obvious here that, COVID-19 really fundamentally altered both public health and the care delivery environment that we're operating in. I'll just by way of a very brief story, NORC was funded by the Robert Wood Johnson Foundation starting in January of 2020 to do some work with large national Medicaid managed care organizations in better understanding how they make determinations around their investments in the social determinants of health. You know, when they make investments in housing or food stability or other things that might be help people live more stable in more stable environments. And in March, we started that project in January. By March, COVID had hit, and we pivoted our project at the request of the foundation to really look at how can managed care organizations be much more supportive of provider organizations at a time when those provider organizations were needing to make changes in how they were delivering care, meaning that things were shifting more virtual. Outpatient surgeries were being canceled and elective surgeries were being canceled. A lot of things that were occurring in the environment. And then by, over Memorial Day weekend, the George Floyd killing happened. And a lot of the focus in that project became about equity. And it became about how do we ensure that the health system and our supportive systems are more focused on ensuring that everyone has equal access or at least access to care in equal ways. Which just goes to show that COVID-19 and the surrounding events that occurred in the last year really fundamentally shifted in really rapid ways and in ways that I think could be that kind of caused a lot of whiplash at times, things to change quite a bit. And it provides opportunities behind that, but also challenges. And so I just want to state that up front, because this really has changed how things are being thought about. I'll just mention a couple areas for COVID. One is that there has been obviously a very evolving areas of focus within COVID. We moved from trying to figure out what COVID was and being able to actually test for it and the challenges that were inherent to that, to then moving towards testing and tracing and quarantining that occurred. One of the things my organization had the opportunity to do this year was really help to oversee the contact tracing work on scales that no one had ever really done contact tracing work. We did that in the state of Maryland and the state of Delaware and for the city of Chicago. And it was a very, I think, interesting and fascinating rollout of how all of that occurred. And then moving to the vaccination stage. So we sort of moved from this testing onto the tracing, and then as the vaccines developed, vaccinating populations and trying to get to as many folks as possible. On the vaccine side, we moved from sort of initial focus on elderly populations, and then after those populations moving through to younger populations where we were really doing widespread distribution, widespread shots in arms. Now the focus has become much more about how do we go about reaching harder to reach populations? How do we go about reaching those who may be concerned about the vaccines, and more focused outreach in those areas. So there's been an evolution over the course of just a few months in terms of how that work is going. But one of the things that also occurred was a disruption in care models, and also accompanying that, a disruption in revenue flows. With the late first quarter, early second quarter changes of 2020 changes that occurred in a lot of less care of the model of care delivery and site of care delivery changing, that impacted on revenue flows for providers, which then pointed to some flaws potentially in our reimbursement system. If a model is based on fee for service, but there aren't patients coming through the doors, and those aren't being necessarily reimbursed or paid for, yet we still need those providers to be there and be in business, particularly safety net, but across the board. How do we create models of payment that ensure when situations like that occur, the system is much more resilient than it maybe was shown to be in the spring and early summer of 2020. I've already mentioned this, but I'll just mention again, one thing that COVID did was delayed bare disparities in access and outcomes. We know, for example, that rates of non-white populations had higher impacts from COVID-19, certainly initially. And that was tied to the fact that those populations oftentimes have higher rates of chronic disease, which was an underlying risk factor for COVID-19, which led to those higher rates. And then also the social conditions, the working environments for that are disparately focused towards the less ability to work at home, oftentimes working in jobs that were deemed essential during the early days of the pandemic led to likely higher rates of infection. So you see all of these things kind of coming into play. And all those are really informing right now and impacting on how policymakers and others are thinking about broader reform initiatives. Go to the next slide, please. And I'm just going to tick through a few things that are areas of likely focus under either the Biden administration or where some states are focusing. This is not by any means a comprehensive list, and it's just some things that sort of came top of mind that we certainly have been noting and hearing and seeing as areas of likely focus. And I'll talk a little bit about each of these. The first is value-based payment. This isn't new. I think this has been it's been a focus of at least the past two administrations and probably a little bit upstream from that as well. But really it's this notion of paying for outcomes and paying for value as opposed to the more widget-based fee-for-service system that we've had. But those transitions take time, and they certainly is likely to continue as an area of focus. But I think we're seeing some evolution now, likely away from some of these broader one-size-fits-all, more national models being developed and pushed out by the federal government, to more local and regional models that are aligned to the needs and the care delivery systems that have developed in those areas. And I think that's a natural evolution. You have to start somewhere, learn from it, and evolve it. But the information that we've been hearing from our federal contacts is that there's a real focus on ensuring that there is resiliency, as I said earlier, in the payment models that are being developed, and hopefully alignment to a greater degree. I think you're likely to see a higher focus on population-based models that are also more focused on things like primary care, as opposed to some of the specialty models that were developed maybe 10 years ago and were being looked at by the Center for Medicare and Medicaid Innovation, who is driving a lot of the work on these types of models at the federal level. We're hearing, things like global budgeting, where particularly for rural providers, as being an area of potential opportunity. And I think you'll see models that are trying to match the goals of what we would like to be able to have of a more aligned, more rational payment system, but being able to align that to what makes sense at more local levels and what makes sense from an overall sustainability perspective moving forward. I've already mentioned health equity, and I'll mention it again. NORC is in the process of examining and responding to a request for proposals from the Federal Health and Human Services Agency right now that's really around helping to advance value-based payment models across the United States. And one of the things that's showing up very clearly in that request for proposals from the federal government is this notion of health equity, that as we build payment models, they're very planfully saying, we want a lens that ensures that as those models get built, A, that they don't increase inequities in healthcare, and B, that they be done in a way that have an opportunity to actually increase that. And so I wanted to mention that clearly because that's very clearly coming through in a lot of the work of the federal government or in this administration. We're also seeing it a lot in state Medicaid requests for proposals as well, particularly those who are focused on managed care and those contracts, but not exclusively states that are doing managed care, even in areas where there isn't managed care, where that is not part of the state's Medicaid program. This focus on ensuring health equity seems to be fairly widespread across red, blue, and purple states. Related to, but not the same as, the social determinants of health, which is another area of focus. The work that we recently did with our Medicaid Managed Care Learning Hub, the Robert Wood Johnson Foundation project I mentioned a few minutes ago, we talked to a lot of health plans, we talked to a lot of community-based organizations, and we talked to a lot of Medicaid programs during that process. And they were all very clearly aligned on the need for us to continue investment, or to make investment to continue to get upstream to address the social determinants if we really want to get to a more rational and fair system that can drive towards greater health equity, regardless of where those disparities exist within your given state. Things like ensuring housing stability, figuring out ways to address food instability, even issues such as transportation and other things. And in particular, within the state Medicaid programs, although I think that the Medicaid program certainly said we're a part of this, and we do manage populations that are disparately impacted by the social determinants, but it has to be part of a larger sort of effort overall. A fourth area that has been around, and certainly in the state of Alaska has been a very important part, and became more so in the other parts of the country during the pandemic, is I say it as tele quite a bit here, because I think you're going to continue. Telehealth obviously is something that grew dramatically during the pandemic. It's an area where a lot of the restrictions around payment and site of care were frozen or changed during that time. And I think states are going to continue, and the federal government and private payers are going to continue to examine which of those changes makes sense to continue, because I think folks, A, liked telehealth, but B, we're still learning the impacts fully of that. And there's studies in the field that are trying to learn what worked and what didn't, but I think you're going to continue to see a lot of that issue moving forward. A fifth area is behavioral health and substance use disorder. On the behavioral health side, this really came to this has been a crying need on the mental health, behavioral health, and SUD front for many years. I think it certainly grew a great deal during the pandemic as issues of social isolation and other things sort of came to the fore, and were being seen, I think, by populations across the board. And certainly this is an area that Medicaid programs have long looked to because of the needs of the populations that are served by Medicaid. But I think even more broadly, it's become a larger need societally, and that will likely continue to be the case. I mentioned non-traditional providers and linkages to community-based organizations as being something we're hearing a lot of out of the Biden administration. Their recognition that in order to meet the needs of a broad spectrum of individuals, that's likely going to mean that we'll be needing to tap into a broad spectrum of providers and needs that people have, not just in a clinic or in a hospital, but external to that. Again, tying back to social determinants of health and health equity, how do you ensure that those partnerships that can actually hopefully keep a person stable without the need to hit a provider, how do we ensure that, or better ensure that as well? And then I mentioned just a couple more. One is the issue of data and transparency. Smatterings of states that are looking at this issue. One thing that's going to spur, we think, some additional work in the data and transparency area is the money that came from the No Surprises Act, which was focused on, of course, third-party billing and other things, but also provided funding for states to establish or enhance all payer claims databases within their states. And so that funding will become available starting sometime after September of 2020. And so there's some, we think that'll spur some additional activity around the country in that area. I think one of the big questions there is data towards what end, and how will that information be used to better advance understanding of healthcare quality, of healthcare cost drivers, and in a way that can hopefully advance health policy more broadly. That's, again, I think very importantly, appropriate to the given state or region that one is working with. And then the final thing I'll mention here is that during the public health emergency, there has been coverage continuity and some expansions of coverage that have occurred through either state-based exchanges, through the federal exchange, or within state Medicaid programs with the enhanced FMAP and the continuity of eligibility that was required under that. So I think that there will be continued examinations of wanting to sort of figure out ways to ensure that there aren't large drop-offs as a result of the ending of that. And again, I think those will be decisions that will be made locally, but I think from a Biden administration perspective, they're certainly coming at it from a preserving as much coverage as possible perspective. You can go to the next slide. And then the final slide I'll mention, or final kind of set of bullet points I'll talk through here, just some things that Medicaid programs are thinking about. This is by any means not a comprehensive list, just a few things that we've heard in talking with Medicaid folks. One is the continued unwind of the various changes or modifications that were intended to address COVID-19, whether that was changes in the way that telehealth was authorized, whether it was changes to the way that providers were paid, how contracts were modified during that time to ensure a flow of money, how enhanced match rates might have impacted on decisions that states made, but they have to plan to the future where that might not be the case. So there's just a lot of that work that's occurring right now within the various states, and that's going to continue to be the case. I've already mentioned value-based payment. That's one that's a lot of state Medicaid programs are looking for. And in particular, I think they're looking at ways that they want to use their contracting opportunities with either managed care organizations, if they happen to be a state that's doing that work, or with their providers who are delivering care in fee-for-service states, to examine ways to continue to advance paying more for outcomes within their Medicaid programs, differently than paying for each unit of care. And it's going to look different in every single state, and it has to be appropriate to the conditions and history that a given state has. But nearly all the states are really examining how best to do that within their given state. I've already mentioned substance use disorder and behavioral health, and the key importance that state Medicaid programs place on those, on ensuring that those services are delivered, particularly given the vulnerable populations that are often served under Medicaid. That's an area that state Medicaid programs are continuing to look at, particularly again in wake of the pandemic, when they know that some of those needs were likely heightened, and in some cases, because of the pandemic, we're not able to meet at the same degree that they were able to. So there might be some pent up demand and some pent up issues moving forward that they'll be looking at. I think states are increasingly interested in what connections are the health system having with the non-health system. How are we better linking our public health, our social services, and our care delivery sides? What are the connections that are there that can help people get the non-medical services that they need, that hopefully help them to not become as chronically ill or as in need of the medical services that might otherwise be the case. And then the final thing I'll mention is there's just an overall there was enrollment increases that occurred during the pandemic. There were costs that were increased during the pandemic during certain times. States are very aware of the fact that those costs are high and that they're growing. And so just overall programmatic costs and management ties back to everything we've sort of talked about earlier. What practices are states looking to put in place to better ensure that they're getting good health outcomes? What we're seeing in a lot of the contracting practices are these movement towards a value-based payment, which hopefully will help, but also movements around how do we as a state Medicaid program better support investments in the social determinants of health? Who are the right partners to do that? How do we move more fully upstream to help to prevent some of the exacerbation of conditions that folks have? So with that, I will stop. And thanks for giving me the opportunity to frame up a few of the issues that we've been hearing.
Well, thank you, Scott. I appreciate your comments. Now let's turn to Commissioner Crum for his remarks. Commissioner, please unmute and begin your remarks.
Afternoon. Sound check. How's that work, Scott? Coming across?
Sounds good.
Thank you. Well, good afternoon, everybody. It has been a long year and a half. as we've gone through this process. I always appreciate Mr. Leitz talking and the information he has to share, because normally at this point in a presidential administration, you would have a lot more healthcare initiatives that would have already been offered up. Right. So, one of the things that we are particularly really trying to do in Health and Social Services is to share kind of like what's possible. 2016's SB 74 Medicaid reform bill allowed a lot of flexibilities to the department. And so we have been working with a consultant from PCG, or Public Consulting Group, to actually share, put together authorities that we already have and a menu of options that are possible in Alaska. Because one thing we do know for sure is all the easy buttons have already been pushed. You can continue go to the well of provider rate cuts or withholding inflation, but that does nothing to change the system for the better. It ultimately just disrupts the way hospitals and providers operate. And so the best thing to do is, how do we actually come together and actually lead some innovation change? Because we've got to dive into this together. As Scott had mentioned, there were eligibility issues throughout the pandemic. By taking the enhanced FMAP of 6.2%, we actually agreed then that we would not do any eligibility review of the Medicaid system. And so while the public health emergency is in place, and by all accounts, the Biden administration says they will continue it through the end of calendar year of 2021, we cannot do anything, no scrubbing of the rolls or just eligibility review, to make sure that even if folks that have moved out of state, they're no longer on our rolls, just so we have a true data of individual utilization. And so this is something that we'll be looking at. We're going to continue to review. Other items that PCG put forward, I know this is something that Providence has definitely looked at and tried to do home. And this is about actually providing, it's a 90% federal match for care coordination expenses over the course of 8 quarters. The nice thing is you're getting this kind of population that you really want to make sure get access to primary care, because as the previous presenter had shared, expanding coverage is kind of the easy thing to do. It's actually getting people to utilize it in the right way, to make sure folks are going to their primary care provider, that they have access, that they understand the resources that are available to them. And so this is why what we're trying to look at are regional based solutions in order to get people connected with local healthcare providers to just use and learn the benefits of healthy lifestyle. Overall, what we can do as a state, and it's a very big push, is really addressing the time between chronic health, what's important than prevention is, getting up front to the upstream side. Alaska is in a unique position because more often than not, when we could travel, going around, go to seminars, I'd have colleagues in other states say they would use an incentive to bump. In Alaska as well, we are 26% above Medicare rates as a composite. And so it's interesting that, while Medicaid budgets are, larger shares of a state, the Medicaid system in Alaska has disproportionate influence on the private sector market, because this drives rates and sets up providers for what they're doing. It also sets up for the private sector insurance as a whole. And it's, there's a lot to that when it comes to the cost of capital construction and other items, getting providers and recruitment. There's a lot of unique challenges in Alaska. And so it's just, how do we address this as a whole? When you look at overall the size of the department, largely due to Medicaid, Department of Health and Social Services has a budget equal to 11 state departments, the governor's office, the court system, and the legislature combined. And this is why one of the things we have put forward was this executive order to restructure the department into 2, to take our direct patient care aspects, which is Office of Children's Services, Pioneer Home, API, and Juvenile Justice, and move them into their own department and keep eligibility in public assistance, the Medicaid divisions of public health, which are really program driven, and make those into the Department of Health. So while we contemplate that, and the governor is actually asking about sharing that, and reintroducing that at some point, one of the things we are working on is making sure that we continue to address directly this upstream issues. And so now that COVID is unwinding, we're taking a focus on our public health side see how important that is across the state, and how do we integrate that more? How do we address and use the data we have from our epidemiologists, knowing about the benefits of healthy living, healthy lifestyles, activity, and really share that to really encourage people to adapt these healthy behaviors, and knowing how important it is to do well child exams and getting into this rhythm of a healthy lifestyle, because there's a benefit there on preventing chronic disease on down the road. So these are items that we are addressing. We're going to continue to push this. Over the next year, I hope to address a little bit more items beyond just COVID as we do this together. I appreciate groups like this that are stepping forward and trying to ask this question, because fully aware, being a business owner myself, about what the rising cost of healthcare does to your employee, to your company, what it means, what you can offer to your employees, and what it means to families as a whole. And so we know that a healthy system allows for healthy people. And so we need to work on that together. So I'll stop there to allow enough time for questions. I just appreciate everybody letting me come.
Thank you, Adam. Scott, Commissioner Crum, I want to thank both of you for your remarks. Healthcare is a complex, often vexing topic. And thank you for helping us understand how healthcare is being transformed elsewhere, as well as here in Alaska. Let's now turn to questions and answers. Juanetta, do we have any questions from the audience?
Yes, Scott, thank you. I'm going to bring everybody back in. Before we get started with questions and answers, I'll just answer the one question that always on everybody's mind is, yes, we will share the slide deck, and we will share a recording of this session. It will be emailed out to registered participants, and it'll be posted on the event page likely later today. So you'll be aware of that when it's available. I'm also going to bring in Preston Simmons and Ralph Townsend and Kathy Giesel and ask them to kick us off with any of the questions that they may have. So Preston, do you want to start us off?
Sure, I can do that. And first question I would say for Commissioner Crum, and I know one of the areas that you have great interest in, and you mentioned, and also in terms of Scott, is moving upstream and working and creating better health, which ultimately will help decrease our chronic disease costs. But also major driver in our expense are those patients that we have in the state that do have those chronic diseases. What kind of thoughts do you have around programs we could put in place to better address that folks that are dealing with like the diabetes or chronic heart disease right now, and those type of things that would help create better outcomes at a lower cost for us?
Some of the 1945 health homes really help. I know that there was a bill that was talked about this year as direct primary care access. Individuals like that who really do struggle with the chronic, studies show they typically don't have a strong primary care aspect in their life in order to manage those issues. As we know now that, diabetes has evolved tremendously over the last 40 years in the manageability of it with drugs, and even some certain low-cost drugs that can help, particularly on the type 2 side. And so getting access to that primary care, finding ways to remove barriers for individuals to travel there and transport, such as social determinants of health, are really big items that we need to do. In order to move even further upstream, we're really working to empower groups within my public health section. I've got a whole section on chronic disease and illness prevention to educate schools. There was a really neat pilot project that was done in Petersburg where they actually worked with the school district and they removed all sugary drinks from the school. So the vending machines didn't offer that. And what they've actually seen over a couple of years has been a decrease in type 2 diabetics throughout the community. The kids talk about it now when they go home. It's actually had a spillover effect into conversations with parents and family members in the community. And it's just been such a positive thing about the benefits between, drinking water and healthy and things like that, as opposed to the sugary drinks, that little things like that seem like small things, but the benefit of that, it really opens the door to conversation.
Thank you.
Okay, Ralph or Kathy? Kathy, you want to go?
Sure. Thanks, Juanetta. And I just want to say I love what Commissioner Crum just talked about with sugary drinks. Full disclosure, Mr. Leitz, I am a nurse practitioner, and I practiced in rural Alaska, actually in those very rural schools and the sugary drinks. I have some great stories about changing lifestyles with those. But, you know, when we talk about value-based care, again, as a clinician, that's based on outcomes, which I actually, as a clinician, can't control. That is in the hands of the patient, right, of the client. And so, have you seen any best practices in other states that really motivate people? Is it really managed care, having an assigned nurse or other person constantly touching base with the individual, helping them through the process of managing their disease? What are you seeing?
Yeah, it's a really good question. And you raise a really important caveat or consideration that has to be there around how we structure value-based payment models, because I think what we're learning is that if you can get the incentives aligned very well, so that the patient has an incentive, the provider has an incentive, the insurance company who's paying the bill has an incentive, then you actually can drive changes in behavior with patients and otherwise. Where we don't want to drive, though, is that we put an incentive in place. Say we're sort of saying, well, we'll pay a global payment to you to manage this care, and then it becomes all the responsibility of the provider at that point. And that's not the models that we're looking that I think folks think are likely to be successful ones. So directly to your question, a couple states I would mention. One is in the state of North Carolina. They're doing some really interesting things around funding. I'm trying to think of the exact name of it. Of course, I'm blanking on it as I sit here. Essentially funding local organizations or regional organizations to be responsible for the delivery of social determinants of health to patients, to ensure that there's some coordination that occurs regionally. Because if you think about SDOH and community-based organizations, they're by their nature extremely local. And to try to sort of manage that at a state level while also sort of manage it at a state level, but to have an expectation that care is being delivered at a very local level with community-based organizations is very challenging. So the way that they've tried to crack that down is to roll that up into a slightly more regional level that helps to manage the delivery of SDOH services out to Medicaid enrollees at a more local level. So I think the best way to get that engagement is through means such as that, and then with close coordination with that primary care provider. The commissioner mentioned the work that's being done and can be done through healthcare homes and through medical homes. That's a great model to build on, but you want to make sure that those pieces are connected in a way where the supportive services, the non-medical services, are done in a coordinated way. That was one example that came to mind as you asked that question, but I think you raise a really important caveat. One thing I will just briefly note is I know in some discussions with folks who are in listening to podcasts and other things and hearing about what directions that some of the leadership at the federal level is thinking about right now, I think they're very cognizant of the fact that we chose to put in those initial value-based payment models a lot of risk on to providers, but not necessarily the level of supports that they need or the level of patient engagement that they need to really make those models work. So I think there is some acknowledgement that we have to continue to work on that.
Thank you.
And Ralph?
I guess actually I'll follow up on Senator Giesel's question about value-based care. You touched on the idea that there are models, a lot of models being explored, particularly in Medicaid and Medicare. Some of the, I guess my question gets to the sort of the economic incentives built into value-based care share some commonalities with the old managed care models, capitation, sharing of cost savings, et cetera. And obviously managed care was was unpopular in a substantial part of at least the private insurance market. And we saw a number of legislation, the annual provider bills in particular. And I guess my question is, do we have a different sense of the economic incentives for the new managed care models? And I guess the second part of my question is, given the unpopularity of managed care for private insurance, are we going to see value-based care primarily in the public programs, Medicare and Medicaid, for the next few years?
I'll take a stab at that and give you some thoughts. First of all, I think a key element to ensuring that the models that get put in place that are intended to maybe make incentives in the system a little bit more rational. Where managed care initially really ran into challenges is when folks felt that they were being either, I'm going to use this with quotes, denied care, or they're not able to see the provider that they want to see. Right. This notion of freedom of choice is very important to people, and that that came through in some of the discussions around managed care, particularly when they didn't feel that they had a say in it. So, for example, my employer is choosing a plan that has a restrictive network. That's my employer's plan. I don't really have a choice on that. The employer might be making a very rational decision because the price point might be one that he or she can afford, but from a patient perspective, it might have been less than ideal because of that sense of restriction. When we talk about the value-based payment models, I think that's something that's going to be really important, that people not feel, so from a consumer perspective, that they're being restricted in any way on. I would also add that when we did move in the 1990s, for example, to kind of pure provider capitation models, that did not go well as an experiment at all. Providers shouldn't have responsibility for trying to predict the risk of the patients and accept a capitated payment for what might be a course of delivery that they don't know is what it's going to look like over the course of a disease course or the like. So I think the models that are being constructed now are attempting to do things like shared savings, where you have some incentives to manage care, you have some incentives to get a real good health outcome at as low a cost as possible. And if you're able to do that relative to a target, you're able to share in some of those savings as a provider, with part of that accruing to the state. I think one of the things that the federal government is interested in building these models is that they don't necessarily want to build them solely for public programs, but they would like them to be more broad spread. And the reason I think that they're thinking about that is, I know when we talk to providers tell us, I don't want to have a bunch of different payment models that are out there that I'm trying to manage to. I want sort of a little bit more consistency and alignment across those. So I think the federal government is trying to respond to that, but they have to be ones that are built rationally for local conditions and that are responsive to provider concerns. So I'll stop there, but that's sort of a few thoughts on the question.
Okay, we have a number of questions actually that revolve around the topic of all payer claims database. And I'm going to try, and this will, I think, reach out to both Commissioner Crum and to Scott Leitz. First of all, the question of the affordability or sustainability of big data projects like that, and how soon, if one were to be established in Alaska, could it be available? Scott, I think I heard you say that it may be some federal funding available for those types of projects. And if you could speak perhaps to whether or not you see that as formula funding or competitive funding in the future. And and then Commissioner Crum, if you could speak to the current legislation to establish something like that in Alaska. So let's start with Scott and then move to the Commissioner.
I'll be really brief. The federal bill, the No Surprises bill, was one that provided, I'm going to get the exact amount wrong, but essentially $2 million, I believe, per year. It is not a competitive money. It's for all 50 states if the states choose to take it. It phases down a little bit over a period of 3 years, but I believe the initial year and the second year, I believe, have full funding available, and then it may phase down in the third year. So there are, but essentially it's targeted to have, I believe, $2 million per state on money that goes out, at least in those first 2 years, and I think goes down to $1 million in the third year.
Great, thanks. And Commissioner, can you speak to legislation and any movement on creating an all payers claim database?
Yeah. Senator Heffern and the Alaska Healthcare Transformation Project have done a tremendous job in putting together information on how valuable to Alaska that an Alaska All Payers Claims Database, or APCD, would be. There was a bill that was introduced in prior session that got pulled, and so it was reworked in the interim, and then Governor Dunleavy introduced one this last session. We've had some pretty good hearings on this. This is a bill that would sit in the Division of Insurance under Department of Commerce, Community and Economic Development with Lori Winghire. And it would be a valuable tool for Alaskans. And so we're going to continue to work on that to make folks comfortable with this. You know, it was not an expensive program when you look at the overall cost of care in Alaska. I think it's an important tool, and I think it's, you know, one of many tools that we need to help us really address the cost of care throughout the state.
Okay, thank you. A couple of threads I want to pick up in some of these questions too, with regard to cost of care reduction. Commissioner, could you also speak to the multi-state nurse licensure compact?
Huge fan. Very, very big fan of the reciprocity that you get from a multi-state licensure compact. I think it's a critical aspect for Alaskans. You know, this is how we get individuals that have met a baseline of credentialing. I think it expedites the process. You know, throughout the course of the pandemic, Sarah Chambers, the director of professional licensing, has really worked with the boards, and they've done a good job responding to this. But I think we can be a little bit faster in how we respond and acknowledge the standards of professionalism that individuals have when they carry into the state. I know this is a conversation I've had a lot with the Indian Health System. AHTP is a very big fan of this. And so I think this is something that would be important for Alaska overall, just to make sure there is this flexibility of talent and professionals we can bring to Alaska.
Okay, great, thank you. These next couple are for you as well, Commissioner. Can you speak in general about Alaska's movement or lack thereof towards a value-based payment system? And then also earlier during the legislative session, there was a proposal to restructure HAS. And are there any potential connections with that restructuring and expanding access to preventative care as you see it?
Thank you. So the Office of Rate Review sits in the Commissioner's office, and we've been working with providers in ASHNA over the last year and a half about DRGs, or diagnosis-related groups, which is a step towards value-based payment or bundling of payments. And so this is something we need to move to in Alaska. We are one of the last holdouts when it comes to fee-for-service. And so there's that aspect. The other thing that we're looking at, and I'm glad Scott mentioned that the Biden administration is willing, is we really want to address and bring up global budgets and regional utilization in Alaska. Alaska, I don't remember, if everybody remembers, throughout the early 90s, there was these placemats that they would have on tables. They would say the 6 states within a state and the different regions around Alaska. That has always stuck with me because Alaska is so diverse on even the people that live in certain areas. Are they living together in certain areas? Are they dispersed? What is the healthcare access they have there? And we can look at that a solution for Anchorage is not going to work for Fairbanks, is not going to work for Bethel or for Barrow, and that we need to find these local solutions. And so this is something that we're definitely looking at. We really would like to do. The problem with this is time and bandwidth, which is why we put forward the restructuring order. If half of my duties could move to another department to where then I could focus and work on negotiating with federal partners and local providers on how we can do these smaller innovation projects on a regional basis, we have a much greater chance of success for commissioners in this role to actually lead innovation that way, to actually work with stakeholders and do further engagement. And there was another part of that, I apologize. It was about
the restructuring of DHSS and focus on preventative care. Was it aimed at increasing access to preventative care?
And that is actually one of the other main goals, is because if we're having just simple program focus, we can actually take public health, use the data there, and work with directly all of the Medicaid divisions. Because as it is right now, Medicaid divisions have very specific ways in which we can expand Medicaid service. When I say expand, I mean like using demonstration projects, collecting data in a certain way, proving to CMS, yes, these worked, and yes, they will qualify for an enhanced FMAP based on qualifications. And so little things like that require time and effort. The Medicaid divisions as they are right now manage certain programs, have to do state plan amendments, and have to make sure checks get out the door. Whereas public health can work to help lead the innovation side. So this would absolutely be a step in that direction and would expand the room for us to have those conversations. And believe it or not, that was actually why I had hired Doctors Inc. While she's been fantastic throughout COVID, that is her passion in life, is actually improving the system of care.
Okay, great. Another question for you, Commissioner Crum, is about the continuation of telehealth coverage and whether or not we have any flexibility moving forward, particularly Medicaid, outside of the public health order.
So we've really relaxed rules and regulations around the delivery of public health, or sorry, of telehealth. We've not had the disaster declaration since February 14th, came in April 30th, and we got rid of that. But as we move that ahead, a lot of the flexibility that allowed there was, around rates. It allowed the same rate for telehealth, to charge a brick and mortar rate as opposed to phone call rate. And there was flexibilities that the the CMS provided us. For example, Norton Sound took advantage of using two-way radios and little things like this that were very region specific, but very defined tools. So our MCAC, which is our Medicaid Clinical Advisory Committee, is a provider signed up that volunteer, and they work with the division to put forward ideas. We're continually to look at how we can address what were the improvements that were made because of telehealth. Are there regulations that we need to change, or is there statutory changes that are needed? And also, there's quite a bit of federal changes that are going to be needed in order for CMS to allow some of these flexibilities to go on. So we've got work groups. We're also partnering with our tribal health providers to meet on these subjects. And what are these most important things that we really need to fight for? I also know that Director Chambers in Commerce is actually really working on this as well, about what are some of the statutory changes. This was something that Senator Costello initially put forward in a telehealth bill, and perhaps some of these items may get addressed in next year's session. But there's a lot of good that came out of that we want to make sure stays in place.
Great, thank you. Scott, I have a question for you. Sandra Heffern's online with us, and she's wondering if you have any thoughts on the public option plans that have been adopted in Washington and Nevada. Any pros or cons that you see with those plans?
Sure. I think a couple things. One is that without having dug into the specifics of those bills, a couple thoughts. One is that I think that when I ran the health exchange in Minnesota for before moving on to NORC, and one of the things that we ran side by side with our exchange was a program we called Minnesota Care, which was a legacy program within the state that operated a lot like a public option. It was essentially a state-run program. It was income limited, so you could only enroll in Minnesota Care up to 200% of poverty. And there was premium payments, but those premium payments were capped, and the state sort of picked up the rest of the risk on it. And we saw enormous enrollment into that program because it was affordable for people at lower income levels. I think that states examining those types of programs, there is definitely a pro in the sense that you can construct a program that is potentially a little bit more affordable for folks at lower income levels. The second thing is that one thing that is a pro related to it is that you're sort of building on a system of where the government has already had invested in administrative costs to run Medicaid programs, for example. So there's not like a duplication of that. So you might get some savings in that sense. The third thing I would mention is a key consideration in putting together a public option is at what income level are you allowed to enroll in it? But secondly, what are the payment rates that you pay under that program? Are they Medicaid rates, which are traditionally lower, although not in Alaska? Medicare rates, which providers are traditionally more used to because Medicare program is so large, or are they closer to commercial rates? And depending on which of those you pick, the cost of the program becomes higher. The amount of the subsidy the state needs to have into it becomes larger as well. So there's just design considerations there. And obviously, if it's at a Medicaid level for most states, that's problematic because getting provider participation and concerns about the sustainability over time becomes a challenge.
Just for the audience's information, Commissioner Crum had to leave to go to a cabinet meeting. So we thank him obviously for his time. And Scott, I'm going to pose just one other question to you, and I apologize for the ones that we're not going to get to today, but there are some additional questions about the all-payer claims database. And going back to our first question, which sort of like, how do you get funding and support for a project like that? And now we've heard that there's federal seed funding that will incentivize the states to work towards the development of that. But then there's an obvious concern that's also expressed about the cost of those kinds of systems and managing costs. And so what are the cost benefits of having that all payer claims database, and what are the sort of the evidence-based outcomes that you're seeing around the country with that?
Yeah, it's a really important and good question. I think it's an important consideration that all payer claims databases are not free. They require both an investment on the front end to establish the system, to bring in the data, to house that data, and then to run analytics on that data. And I would also sort of just mention that it isn't free to the state, and there's some cost to the providers or to the entities who are putting data into some administrative cost that is associated with the transfer of that data. So those aren't zero. The question on cost benefit then becomes, are you able to then use the information that comes in a way that creates transparency and information that payers and providers and consumers are able to use, such that the benefit that goes in, that accrues as a result of that data offsets that initial cost or the ongoing cost. And if you think where a lot of states have really focused has been, how can we use, for example, that information to better understand when we were very, very concerned about the opioid addiction crisis, and we still are, but certainly it's been transplanted by COVID and other things, but it's still out there. A lot of states were using their APCDs to really hone in on where are the prescribing practices differences. How do we get information out that's able to identify where those areas are, and then how do we put in place policies that are sensitive to those changes. So that would be one example of how those have been used to hopefully A, get better outcomes for people, and B, get lower costs as a result of it. So I think it's a great question. The other thing I would say is that as you move forward in trying to reform a system in ways that are appropriate to the local conditions and the local providers and local payers and local consumers that exist in a given state or region, it can be a challenge to do that without good information around what the current state of the world is, around what the current costs are, what's driving those costs, what's driving poor outcomes, and the like. And then that becomes a really important thing if you're actually trying to make meaningful change across the system, which is, I think, why we identified the data piece as being a really important one for the state of Alaska, because it was an area that just stood out to us as an opportunity. And fortunately, there is some seed funding that is coming down the pike that hopefully will mitigate against some of the costs. But as you said, it's not free, and there would still need to be a plan in place to make such a system sustainable and analyzable moving forward.
All right, thank you. Well, Sandra also offers a comment that Friedman Healthcare provided a report on the Alaska All Payers claim database, and that's available on their akhealthcaretransformation.com website. So encourage folks with an interest and lots of questions about the database here today. So let me turn back to Scott. We're a little bit over time. So Scott, back to you.
Thanks. So Scott, I want to thank you, and I know Adam Crum had to leave, but I also want to thank the commissioner for joining us today. I think your presentations provided some interesting insights into the issues surrounding healthcare, the things that are being done. And as a layman who's not an expert in this area, it all looks very complicated. It's been complicated for a long time. Hopefully some of the things you all have talked about today will lead to that goal of equitable healthcare and cost-effective healthcare as well. I also want to thank Preston Simmons, Ralph Townsend, and Kathy Giesel for leading off the Q&A. I'm also pleased to announce that these three will be leading the effort to launch a new Commonwealth North Healthcare Study Group. The Healthcare Study Group has proposed to look at value-based care models with a likely additional focus on chronic disease. The charge statement for that effort is still being finalized. We invite interested members and guests online with us today to sign up to receive more information on the study group and its future sessions. Again, thanks to Ralph and the Institute of Social and Economic Research for sponsoring today's program. We appreciate it, Ralph. We invite everyone to join us for our July program, which will be announced soon. We're working on an infrastructure program, the release of the Arctic Policy Study Group report, and a report on state debt. Also, be sure to check out the Fiscal Policy Study Group series of 3 sessions focusing on proposals for a durable state fiscal plan. First up is Commissioner Lucinda Mahoney this Friday, June 18th at 8 a.m. She'll be detailing Governor Dunleavy's 50-50 plan. Check out our event calendar for more information or the link in the chat window now. Thanks to our members and friends for joining us today. Again, if you are not a member, I encourage you to become a member of Commonwealth North at commonwealthnorth.org. We stand adjourned. Thanks.